It's opening. So give me 1 second.
It has started actually on YouTube.
Somebody on YouTube?
Yeah, I am checking it through other device. It has started streaming on YouTube.
Okay. Somebody on YouTube?
Yeah, I am checking it on
Dheeraj
my
is
other
there.
device. It has streaming on YouTube.
Oh, okay. Beautiful.
Somebody on YouTube?
It's already started.
Nice.
On my other device.
Oh,
Okay.
beautiful.
Somebody on YouTube?
It's already started.
Nice.
On my other device.
Is there some echo, is it?
Beautiful. Somebody on YouTube?
Yeah, yeah. It will be, there will be echo. If you mute the
Is there some echo,
YouTube,
is it?
no, all of you, if you mute your YouTube live,
Our YouTube is off.
okay, so then you won't hear anything. Okay, is it on there? Is it still on YouTube?
YouTube, yes, yeah.
I'll just check YouTube. Yeah, so YouTube live is on.
YouTube live is on, yeah.
Okay, so we can just then wait and then start. Okay. There is 5 more minutes if you want to. It's live anyway, so you can mute and then we'll meet again in 5 minutes. Okay. So if somebody can put up on Facebook that will be live in 5 minutes, or do you want me to do that?
Yeah, it would be great if you can do that. Otherwise, I'll put it on. I put that on other local groups that we are actually live on YouTube. Somebody can put it on Facebook.
Please, Guru, also, can you please tell us how to upload the slides?
I've made you host now, Nagendra.
Okay.
Okay. And everybody can share their screens. Okay. It's already there. So like Aparna ma'am can share her screen.
Yeah, I just did that. Yeah, thank you.
We tried Minati's screen. You want to share your screen and check?
I have already checked.
Yeah. Nagendra, you want to check your screen sharing?
Yeah, allow to share screen.
So is that Guru?
Yeah.
You share your screen, Nagendra.
Yeah, I'm just checking. It's not happening.
No, share your screen.
Share. Go to share at the bottom of your screen. Share. At the bottom of your screen, there must be share option.
Oh, yeah. Allow to share screen, isn't it?
You're made the host, so you can share your screen. Okay.
Yeah, there is a.
That is that. That is it. Okay. So then you can open your presentation also. Okay.
Oh, what have I done? Can you see me at all? Hello, guys. Can you see me? Can you hear me?
Yes,
We can
yes.
hear
hear
you,
you.
we can see you, except that
But
you have you tried your share screen, right? You have done it.
I've done it, but it's not.
I think in the share screen, if you can share that specific PowerPoint window, because that we have not yet seen.
Yeah, that's good. Now share your PowerPoint, Nagendra.
Okay. Yeah. Can you see me now?
Okay, put it on, s- not on this mode,
Slideshow.
but on the presentation mode
Presentation.
at the bottom.
Yeah.
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 Okay, good. All right, it works. So all of
Can you
you,
see my Can you see my slide there?
yeah, yeah,
Yes,
yeah.
Yes.
Yeah, all good, all good. You can click escape and um, we'll go on to Global Anesthetic Society. I will tell what is this called? Perioperative.
It is 6 o'clock.
Yeah. Perioperative medicine, anesthetists as perioperative physicians.
Okay, I'll just share the, give me 1 second.
At 6 o'clock exactly. Yeah.
Okay. So 13 people are already watching now. If you want to start,
I think we should start.
Dr. Nagendra, you have to unshare your screen now. Stop sharing.
Okay. Oh, sorry. Yes.
Thank you.
okay. You can start now if you want to.
Have I not done it? Okay.
You can start the session.
Okay. So we are starting with Dr. Minati, is that right?
Yes.
Nagendra,
Yeah.
as the coordinator, do you want to give some introduction before we start?
Yeah. Yeah. Please. Yeah. I will do. Yeah. Yeah. Can I start now? Yeah. Correct. That's correct. Yes. Uh, yeah. Sure. Will do. Hello, everybody. Thank you for all for attending this webinar on perioperative medicine, anesthetists as perioperative physicians. We have chosen 3 topics which will impact us in our day-to-day practice. The 3 topics chosen are atrial fibrillation, presented by Dr. Minati Chowdhury. Uh, Dr. Aparna is presenting on obesity, and myself would be presenting on perioperative steroid cover and management of flozins. And these topics impact our day-to-day practice. I'm sure you all agree with that. And we'll start off with Dr. Minati presenting the atrial fibrillation. Over to you, Minati.
Thank you, Dr. Nagendra. So today is the day for perioperative medicine. So we as a anesthesiologist are not confined to the management of the patient in the OR. We see the patient in the pre-op clinic. We follow the patient in the ICU and the post-op period as well. So it is called the perioperative thing. So there are lot many problems arise in during the perioperative period. Starting we receive the patient, but out of which arterial fibrillation is the most common one, and the patients come very often. So though this is most common, also this is the most common serious cardiac arrhythmia during the perioperative period we encounter. Almost nobody can deny they don't encounter a patient with atrial fibrillation. And the prevalence of this thing is varies. It all depends upon the comorbid condition of the patient, which surgery the patient is undergoing, and so many other things will come later on. So what is it? This is basically uncoordinated arterial activation so that effective atrial contraction does not happen. So it get manifested in the surface ECG. As you can see, there is absence of discernible and regular P waves. At the same time, there is irregular activation of the ventricle. There is no specific pattern to the RR intervals in the absence of the AV block. So AV block is not there. The other rest of the things are there. This is what the atrial fibrillation we see in the surface ECG. So it can happen as we said in the pre-op, intra-op, and the post-op period. And the management, some management are similar and some management are dissimilar. We have to adopt that. So it can be a first onset or first diagnosed. You may see it in the pre-op clinic or in the intra period or in the post-op period. Patient had no history of atrial fibrillation, no comorbidities, but all of a sudden it started. The second one is paroxysmal atrial fibrillation. This is there. Patient has a history, but he has intermittent history of the this kind of atrial fibrillation, and it usually terminates spontaneously within 7 days once it start. Usually this need intervention in the thing of drug therapy. There is another thing that is a persistent AF. So these episodes are not self-terminating. Patient come with the history of the persistent AF, and the once it start, it stays for 7 days and a maximum for the 12 month. But in this case, not only the rate control, the rhythm control is also done. So patient who have this persistent AF, they usually have a history of drug therapy for all these things. There are some or some other drug, yeah, rate or rhythm control drug, and they come to you. Next is the permanent AF. And in this case, only rate control is done, and the patient are not amenable for the rhythm control. So many of these patients they go for catheter ablation and any other therapy during the perioperative period or in the postoperative period. So another thing is postoperative atrial fibrillation. And at times, patient does not have anything in between or no history of atrial fibrillation in the pre-op or intra period, but it all of a sudden start in the post-operative period. This is usually after a major surgery or after a cardiac surgery, even if the patient is normal sinus breathing throughout. And it is usually occur within 7 days, but maximum peak occur in the 48 hour and last up to 30 days. This usually corrected with the drug therapy, and the time which is required to diagnose this thing. Suppose if you are measuring in a standard 2 lead ECG, you have to measure for 10 seconds. And if you are going for a single lead or multiple lead ECG device, then you have to measure for 30 seconds. So some are patient are asymptomatic and some are symptomatic. The asymptomatic and they don't complain any symptom, and that is usually documented by an ECG for when last for 30 seconds. And some are have subclinical AF. These patients are also presented with the asymptomatic AF, but all of a sudden they manifest this thing. And if you are going for a continuous monitoring like Holter and all, you may have a 30-second episode of AF. And usually Holter you don't do regularly in all kind of patient, but suppose the patient is having a history of heart disease and all, in that case we go for it in the pre-operative period also. In that case, if you see AF, and even if it is one episode, one has to be careful because this is the predictor of future clinical AF. Recent onset, it occur recently, and some are trigger induced. Suppose there is a precipitating factor like electrolyte imbalance and all, these are trigger induced AF, and these are usually reversible. Then some AF are self terminating, they are paroxysmal AF. But all these AF again need the drug therapy at some or some other point. So why it is a concern for we anesthesiologists? Because it increase the morbidity, mortality, hospital stay, ICU stay, readmission rate, and increase total healthcare cost. Because if it is a persist, it gives rise to congestive cardiac failure, myocardial infarction, and thromboembolic event. The last one is very very common thromboembolic event, and all these things, if it happen, it increase the morbidity and mortality obviously. So how we are going to prevent this? Basically, the main our goal is adequate organ perfusion and minimize the complication rate. And one has to, for this, one has to recognize the contributing factor and manage those contributing factor to prevent this thing. Or if it is all already is going on, then you have to manage in the perioperative period. For this, you have to identify the risk factor, if any. So, preoperatively, male sex is more prone if the patient is obese, having hypertension, diabetic, or congestive cardiac failure, both low and normal ejection fraction, any hepatic renal dysfunction, or advanced age, especially more than 65 are more prone. And if they are undergoing a cardiac surgery or abdominal or thoracic or major orthopedic surgery, these are the patients who are more prone. So again, if they have post-operative, suppose the patient is on beta blocker or any of the drug, patient is having persistent AF, but rhythm is control, rate is control. But in that case, if at all you stop the beta blocker due to some other reason or AC inhibitor, whatever the patient is taking, the patient may again land up in the AF during the perioperative period, which is again difficult to manage. Any electrolyte imbalance, especially hypokalemia and hypomagnesemia, these are the patient more prone. Or if landed up in critical illness or sepsis or prolonged ICU stay due to some reason, they are basically prone for perioperative AF. So how it get developed basically? What is the pathogenesis? As you know, the surgical stress and pain both happen during surgery. They lead to sympathetic activation and increase the level of catecholamine. This increase the arrhythmicity and increase the atrial fibrillation. Similarly, both hypercarbia and the hypoxemia, they lead to pulmonary vasoconstriction. They elevate the right atrial pressure, and there is right atrial dilatation, which is again a predisposing factor for atrial fibrillation. And hypervolemia also by the same mechanism, it increases the arrhythmicity by increasing the right atrial dilatation and give rise to atrial fibrillation. Next is both hypoxemia and anemia, hypovolemia and hypotension. These three, they basically lead to myocardial cellular ischemia, and this ischemia, they alter the arterial conduction velocity and further increase the anisotropy, increase the arrhythmicity and atrial fibrillation. At the same time, electrolyte and metabolic disturbance, they also alter the cellular conduction and between imbalance of ion channel between intra and extracellular thing, and increase the arrhythmicity leading to atrial fibrillation. Apart from this, cardiac surgery patients are more prone because in the bypass and in the cardiac surgery, there is increase in inflammatory marker and which has predisposed to arterial fibrillation, especially during the post-operative period. So when the patient comes to us, the patient may be asymptomatic or may complain with palpitation, shortness of breath, chest pain, all these features of the atrial fibrillation if the patient is suffering chronically. And you can take the history, the patient mostly on some drug therapy. So in the pre-op period only, you have to mentally prepare. This patient may have heart failure if they are undergoing a major surgery, may have a risk of ischemic stroke, thromboembolism, cognitive decline, and perioperative delirium or depression while during the ICU stay after a major surgery. So you have to mentally prepare in the beginning so that you can take care of the patient, not only by with the management of the atrial fibrillation, but also the management of the other things. What are the outcomes they can occur due to presence of this atrial fibrillation? So the patient may not have any symptom, may have disability, normal activity may be discontinued. So while this patient come in the pre-operative period, suppose you know the things, you know that the patient is having atrial fibrillation. So take the entire medical history. What is the pattern when what is the onset of the AF, whether it is paroxysmal or persistent, what drug therapy the patient is having, if the patient is on anticoagulant, if the patient is having the risk of bleeding or thromboembolism, then go for the 2 lead ECG and total CBC, RFT, LFT, and serum electrolyte and glucose status, and thyroid function test, because many of the hyperthyroid patients, they are very prone for the atrial fibrillation during the perioperative period. So also a transesophageal echocardiography if the patient has persistent or permanent atrial fibrillation in the preoperative period as such, because you have to rule out any thrombus inside. In some selected patient, go for ambulatory ECG monitoring, especially if the patient is having the history of coronary artery disease, and you have to see whether the patient is rate control or rhythm control. Again, go for the pro-BNP and troponin to rule out any ischemia, ongoing ischemia is going on. Rule out the LA thrombus and the valvular involvement with the TE, but at times some patient like MR and AR, they remain asymptomatic for a quite long time. So those are the cases you can identify in the TE. So they are the specific cases with the permanent atrial fibrillation. You should go for a TE as well if it is possible, and go for a CMR and for the evaluation of the arterial and ventricular cardiomyopathy, and brain imaging for the cognitive function assessment. But these are only for the specific patient, and if the patient is undergoing a major surgery or the cardiac surgery, not for all the patient. And suppose the patient, you diagnose the patient is having AF in the pre-operative period, if it is elective surgery, then assess all the comorbid and involve the multidisciplinary team like cardiology and your surgeon and the internal medicine nursing team, and assess the risk factor totally and start managing. So you have to, so if the patient is not on anticoagulant, then start to avoid stroke and thromboembolism. And once the rate and rhythm control is there, you can take up for the surgery and evaluate this patient intermittently. So the management should be integrated, identify and actively manage all the risk factor and the comorbidities. If there is hypertension, reduce out the it to the target 120 to 129 millimeter mercury by 70 to 79 diastolic in most of the adult. But you can reduce down it a little bit also, and it is beneficial for the patient. Patient is having heart failure, again optimize with the diuretic to alleviate the congestive episodes. Effective glycemic control is again important, and if you can, your patient can lose weight, you have time, and the patient is overweight and obese, then the less than 10% reduction is very very important. If sleep apnea is there, management of the sleep apnea to minimize apneic episode, because the apneic episode also precipitate the incidence of AF during the perioperative period. And ask the patient to go for tailored exercise program, regular moderate vigorous activity. If the patient is on alcohol, again reduce the alcohol consumption to 3 to less standard drink per week. And this score is very important. Chart DS2 or chart DS2 was S score. This is important because your anticoagulation management entirely depend on that. So it includes the congestive cardiac failure, hypertension, age more than 75 year, diabetic, and age for previous stroke. Then the second form, the V is for vascular disease and E is for the aortic disease, and S is for sex, and if the female, then it get 1 point extra. So 0 is low risk, intermediate is, risk is 1, and high risk carries a score of 2. So if the score is more than 2, then consider anticoagulant if the patient is not on any anticoagulant in the pre-op period as such. So to avoid stroke and thromboembolism, start oral anticoagulant and in the concern with the cardiologist. But you should understand, you should not combine antiplatelet with oral anticoagulant in the thought of it will prevent stroke. No, it mainly increase the bleeding risk. Suppose your patient is on a mechanical valve and patient had AF, and but then you can always start with warfarin and keep the INR 2 to 3. Then reduce the symptoms by rate and rhythm control by various drugs, cardioversion or antiarrhythmic drugs, catheter ablation, surgical ablation, or pacing. Then intermittently evaluate the patient, and when the patient is you found is does not carry any risks in the perioperative period, then you can take. Suppose the patient is with paroxysmal AF, so this patient may come with a normal rhythm. They may say they may have stopped the rhythm control drug, if any, and because these are spontaneous onset and revert back to normal sign rhythm without any apparent cause. So these are the patients who are very difficult to manage. So you have to elicit the history in this patient, and if they have any previous episode of AF, if the patient is having comorbidity, we can precipitate AF. In those patients specifically, you can ask for a history and go for a 72-hour rhythm strip if the time allows, because this patient may be asymptomatic, may come with the symptoms. So if it is elective surgery, again follow up AF care like coagulation and evaluation and rhythm management. And the rate control is important. If ejection fraction is less than 40, you can go for beta blocker and digoxin. And if it is more than 40, then you can go, apart from beta blocker and digoxin, you can go for deltiazem and verapamil as well. Rhythm control, usually amiodarone is the best drug, whether it has a reduced ejection fraction or normal ejection fraction. So that is widely practiced amiodarone, but some practice also flecainide and propafenone. Suppose the patient is failed antiarrhythmic or the arrhythmia is intractable and came to the OPD for any of the surgery, it is elective surgery. The patient, if it is convinced, then they can go for a catheter ablation as a first line. Or if antiarrhythmic is failed, the patient is already on antiarrhythmic is failed, then also you can go for a catheter ablation. Suppose the catheter ablation is failed, then again you can redo it or go for antiarrhythmic in the pre-op period. Suppose the patient has a persistent AF, then continue all the drug therapy, and the other management protocol is same as the paroxysmal AF. One can go for AV nodal ablation or pacemaker in non-respondent permanent AF. These are all the in the elective cases in the pre-op period. Suppose the patient does not have any history of AF, and suddenly you in the pre-op period you have seen there is new onset of AF in the your evaluation room, and then you have to think of whether it is an emergency surgery, whether there is elective surgery. Suppose if it is emergency surgery, then you stratify the patient, and you have to see if it made the goal of care and proceed to the surgery. And you have to consider all the advanced monitoring like echocardiography, 2 LED ECG, invasive arterial line, CVP line, all these things. At the same time, you have to evaluate and manage the trigger cause, like if any inflammation is there, any sympathetic activation, or whether patient has having pulmonary thromboembolism signs or electrolyte imbalance, any metabolic derangement, or patient is having high dose of vasopressor. So you is at the same time you have to manage all these things. And suppose the emergency surgery is not there, patient is fit for a elective surgery, but there is evidence of malperfusion, like patient is having syncope, fatigue, and all these things, and if his patient is collapsing or towards some time, at the same time you have to evaluate according to ACLS guideline and postpone the elective surgery. Then again evaluate the patient according to the ESA guideline of the evaluation of AF, like rhythm control, anticoagulant, and follow up. Suppose there is no evidence of malperfusion, then you estimate the perioperative risks of MACE, that is a major adverse cardiac event, that should be based on the combined clinical and surgical risks, and then eh, obtain the informed consent from that patient. And once you evaluated this, then you have to decide whether the patient have low risks or elevated risks. If low risks, then confirm that patient should take beta blocker once, go back home, then proceed for the surgery. Suppose elevated risks, again, if the functional capacity is more than 4 metabolic equivalent while in the AF, then again confirm that patient should take beta blocker when go back to the home after the surgery. If the patient is agreed for that, then proceed to the surgery, but at the same time continue with the advanced monitoring depending upon the patient's comorbidity. Suppose the patient have less than 4 functional capacity, less than 4 minutes, or the functional capacity is not known, then you should go for a pre-op echocardiography. And if you go for a pre-operative echocardiography, you see there is hemodynamically significant pathology, and then consider postponing the case if possible. If proceed for the surgery, then go with the advanced monitoring. And if there is nothing is there, if less than 4 minutes, but you don't know, then proceed for the surgery. So this is how you are going to manage new onset you see in the pre-op evaluation room. Then intraoperatively maintain the hemostasis. You know the patient is having arrhythmia or patient is prone for arrhythmia, AF. Then maintain the hemostasis during the perioperative period. Maintain the euvolumia. Go for a rate control with metoprolol or carvedilol. Mostly metoprolol we use. Amiodarone when beta blocker is contraindicated. Amiodarone is best for rhythm control as we discussed. Suppose the patient is having contraindication for the amiodarone due to some rhythm, you can go for verapamil or diltiazem. Coming to the anesthesia, volatile anesthetics, they do not differ from TIVA with respect of the atrial fibrillation risk. So, but you have to avoid desflurane because it increases the sympathetic stimulation and it has a potential for the arrhythmia. So, avoid the sympathomimetics if possible. Ketamine as an induction dose is better to avoid because it might precipitate, but there is no randomized trial on this. Dexmed is a preferred agent when you go for the intravenous agent. Avoid atropine and glycopyrrolate wherever is possible and if Sugammadex is available. You are putting a CBP catheter, you know RA is very huge and patient may prone for AF, then careful while putting the CBP catheter, it should not irritate the RA. Assess and the correct the acidosis, hypomagnesemia, hypokalemia, cardiac ischemia, all these things. If at all your patient need any inotrope or vasodilator, so vasopressin is a better choice if there is ongoing AF rather than epinephrine or norepinephrine. Avoid dobutamine and milrinone if possible. Phenylephrine is a better choice because it causes reflex bradycardia and it helps. So if you want to see the volume status, and don't go for SBV and PVV because these two are unreliable indicator of the volume status because the diastolic time is variable. If you want to cardiovert the patient, start anticoagulation within 48 hours in the post-op period. Otherwise, there will be thrombotic risks. If the patient is having a metallic valve, then start warfarin. Consider alternative for stroke prevention if anticoagulation is contraindicated in these cases. Coming to anticoagulation bridging and management, suppose the patient is on anticoagulation, if the chart DS score is less than 1, if the patient is having low risk surgery, suppose screen grafting and all, so no anticoagulation alteration is required. And but those patients who are on a high risk, if chart DS score is more than 2, then warfarin target INR of 2 and 3 or oral anticoagulant dabigatran you have to go for. And intermediate score, if chart score again 1 to 2, patient on aspirin or warfarin, and warfarin is better. Aspirin does not decrease the stroke risk, rather it increases the risk of bleeding. So better go for warfarin. And when you want to bridge, that is prior thromboembolic disease and patient with a mechanical valve. Suppose patient is prone for high risk for thrombosis if the chart DS score is more than 4 and low bleeding risk procedure, suppose skin excision and all. So do not alter the anticoagulation treatment. Whatever the patient is getting, let it the patient get that anticoagulation and continue with it. If the INR is within therapeutic range, you need not to change the whatever warfarin or whatever the patient is getting. Suppose the patient have high risk of procedure bleeding, then you have to stop the anticoagulation. That stop warfarin 5 days pre-operatively. INR should be less than 1.5 and go for the bridging anticoagulation with IV heparin unfractionated or low molecular weight heparin. Enoxaparin 1 milligram per kg subcutaneous BD. After this, you stop heparin 4 to 5 hours before, or if at all the patient is getting low molecular weight heparin 24 hours before the surgery. Then once the surgery is over, then restart the warfarin when INR comes to the therapeutic range for at least 48 hours before discontinuation of the heparin. Then only you can start your regular anticoagulation. So only one anticoagulant that have reversal agent, that is dabigatran, idarosizumab. I don't know whether it is available here or not. So otherwise others have no reversal agent. Suppose your patient have intraoperative new onset atrial fibrillation, everything is fine, no history, nothing. All of a sudden, patient in the middle of the surgery start fibrillating, and you have to again evaluate the triggering causes as we discuss: inflammation, electrolyte imbalance, hypotension, all these things. Suppose the patient is hemodynamic stable, then you have to look for a rate control. Go for beta blocker or magnesium sulfate. And then there are two conditions again can happen: target heart rate can reach or it cannot reach. If it is not reached, then rhythm control with amiodarone to be given. If the rhythm control persistent, and then you continue with the post of amiodarone, these patients are go for persistent or recurrent AF. Suppose the patient is hemodynamically unstable, that is saturation, systolic blood pressure is less than 90, then is a sign of ischemia, decompensated heart failure due to all these things, then you should go for the urgent DC cardioversion. But at the same time, you have to consider the rate control with the beta blocker or magnesium sulfate or amiodarone. So patient may convert to sinus rhythm or may be persistent. If it is persistent, go for amiodarone or any other therapeutic mode like catheter ablation and all in the post-operative period. Then in the post-operative, mostly it is self-control, the JF, and it happen 11 to 12 hours after surgery. There is minimal acute alteration in the hemodynamic, and 80% they come back to the sinus rhythm. Again, stable versus unstable, the management is same as we do in the intraoperative period. So the mostly the anticoagulation strategy in the post-op period should be individualized, and but there is no clear advantage of oral anticoagulant over the vitamin K antagonist. So there is some new thing we can predict the new onset of arterial fibrillation in the ICU. One is machine learning algorithm, that is a promising tool for predicting and detecting new onset if in the ICU patient. AI is another mode. Then is some ECG nomogram. From that, one can predict the post of arterial fibrillation. All these things are there to prevent and the control. So there are some consideration which are new, that is the avoid rate control less than 80 per minute from 100 beat per minute, because it is harmful in the patient with the DCM, especially if the ejection fraction is less than 30, because these depend upon the heart rate for the ejection fraction. So you keep the heart rate around 100 to 110, especially DCM with the less than EF 30. If it is not, patient is normal otherwise with a normal ejection fraction and hemodynamic, then you can go till 80. So rhythm control is also important, but somehow the latest guidelines say both rhythm control and rate control in both cardiac and non-cardiac surgical population appear to have equal outcome. Next is anticoagulation, whether to start or not start, whether to go for it early or not. So it is very important to if the patient is having continuous AF, then start the anticoagulation within 48 hours. So there is no genesis of the thrombus. If there is more than 48 hours, then there is genesis of the thrombus. So it is best to start if the AF is less than 48 hours of time. So early cardioversion is again important. If you delay for more than 12 hours, the incidence of thromboembolism or stroke is much more. So you have to go for it early again. And some patient who are susceptible, especially the patient having the history of mitral stenosis and all, in that case, left atrial appendage occlusion or ligation, one can go for before any major surgery and correct the heart situation at the same time. Also, in the post-operative period, patient can go for bilateral pacing, pulmonary vein isolation, or pulmonary vein botulinum toxin, and calcium autonomic denervation. In this case, there is injection of calcium chloride into the major arterial ganglionated plexi, vagal nerve stimulation, and posterior left pericardiotomy. These are some non-pharmacological prevention while the patient is usually going on surgery in the post or having intractable arrhythmia not responding to any therapy in the post-operative period. So to conclude, it is a perioperative atrial fibrillation in the multidisciplinary approach. So you have to identify whether the AF is pre-existing, new, paroxysmal, or permanent. Identify all the precipitating factor in the pre-op, intra-op, and the post-op and correct it. Consider DC cardioversion if hemodynamic compromise. If it is elective surgery, patient have persistent or permanent AF, you can always delay and at least do some rate control. Decision to make whether rhythm and rate control it is preferred of the physician. Anticoagulation is a must if the patient with high risk of thromboembolism. New onset of atrial fibrillation at any point of time is not at all benign, even if when they are hemodynamically stable. So these deserve the regular follow-up and the prompt treatment. So prevention is always better. Early the diagnosis, best the management. You have to be patient specific. All those then don't need the similar type of treatment. And do not forget the new technologies and arrange the appropriate follow-up of all these patients once the atrial fibrillation has happened. Thank you so much.
Thank you, Dr. Minati. That was quite an exhaustive information. I'm sure for most of us, I think it's one of the commonest arrhythmias, as we know, we manage in our practice. Shall we take the questions at the end of all the three presentations, or do you want to take the questions now? Shall we take that at the end of it after Dr. Parna finishes?
Anything,
Yes.
whatever. Anything.
Now,
Okay.
look,
Let's
if you've
Dr.
got any
Parna.
questions, we've got a couple of other panelists here. Dr. Achal Dir is also online. We're
Okay,
lucky to have him here from Canada, who's a cardiac
Anesthetist, yes.
anesthesiologist, transplant anesthesiologist. He might have some pearls and tips and tricks in managing perioperative AF. We can have from there while I'll look up on the YouTube if there is any questions. Dr. Achal or any of other panelists here, if you got any tips and tricks or want to say something, please.
Yeah, thank you very much, Nati. It was a great presentation. So just a couple of points that if it is a paroxysmal AFib, that is, I think, one of the most dangerous forms. If patient is already diagnosed with AFib, whether persistent or chronic, patient is already managed by cardiology by all the cardiac drugs plus the uh, newer oral anticoagulants. But if it is paroxysmal, patient feels that he does not have any arrhythmia and he stops taking those medications and he has maybe one episode every 1 month or every 2 months, or it's not very consistent pattern. And these are the patients who usually end up with having a stroke and major problem. So that is why for those, this CHAD score is very important and that should be on these anticoagulants. Second thing comes about patient who is already on these medications coming for elective procedure and how do we manage? We very well said that, of course, these drugs need to be stopped and whether we should have a bridging therapy or not. Again, that goes to our question on CHAD2 as VASC score. If it is 3, then I think there is an indication for bridging therapy. Again, I should also say that if it is a non-valvular atrial fibrillation that's not related to mitral stenosis or something else, then there is an indication of these DOACs, that the oral anticoagulant, the newer ones. They are not yet approved for valvular atrial fibrillation. So another thing I would like to add is how do we cardiovert any anesthetic management of a patient like you're starting a case, suddenly patient goes into AFib or it is a simple sedation and you're called for cardioversion. So what I found in my personal experience, and that is the safest, is giving a ketofol. So that means 0.5 milligram per kilo of ketamine and 0.5 milligram per kilo of propofol. Just give the oxygen mask. These patients do not become apneic. They maintain their hemodynamics, and you can do at least 3 cardioversion shocks in the time frame of 5 minutes or so. If you give too much of propofol, they become apneic, then you have to have an ambu bag to support. Or if you give midazolam, they sometimes have too much of pain. So in my particular personal experience, I find that ketofol really serves the purpose here for cardioversion. Yeah. Thanks.
Thank you, Dr. Achal. That was quite useful. Right. As I said, regarding the questions from the other participants, we will wait for the other presentations to finish, and then we can take the questions at the end. Over to you, Dr. Aparna.
Yeah, I think we should get going.
Yes, over to you.
Should I share my? Yeah.
Yes, please. Yeah, please do.
Okay. Is my screen visible?
No, not yet.
Shared my. Now can you see my screen?
No, we can't see your screen.
The presentation.
No, we can't. Can anybody see?
No, no.
No, not yet. Not yet.
Okay.
Ma'am, share the screen. There is a green button.
Yeah, that's what I'm doing.
So then click on the entire screen. Then share.
Click on.
Now it is visible. You have opened your PowerPoint?
Wait. Now can you see?
Yeah.
Yes.
Yeah,
Yes.
we can
You see the
Yeah,
screen
yeah.
now.
Okay.
Thank
Start.
you. Yep.
Yeah.
Please do. Yeah.
Good evening, everyone. So, at the outset, thank you so much, Nagendra and all the organizers to bring us all together for listening to such important topics. And so here I am discuss about what are the current concepts which define perioperative safety in patients with obesity. So I have no disclosures to make and no conflicts of interest whatsoever. This talk is based on my personal experience and current evidence. So what is the role of an anesthesiologist? What is the entire role of an anesthesiologist is to ensure patient safety throughout the course of stay of the patient, to plan safest possible approach to anesthesia, prevent any adverse events and complications, and to send the patient back home at the earliest with no harm. So this is a principle that applies to all specialties. So to define what exactly are the adverse events and what exactly are the complications that we do not want in any of our patients in the post-operative period, there is this landmark study which was done more than a decade back, but it still holds good because it forms the basis of most of the research around patients with obesity. So there was a study that was published in 2011 by the American College of Surgeons, where they analyzed 11,000 patients to decipher a national surgical quality improvement program in patients who were undergoing bariatric surgery and had a BMI of minimum 35. So they found that the anesthesia-related adverse events centered around prolonged ventilation, unanticipated ICU stay, complications like renal insufficiency or rhabdomyolysis, cardiorespiratory insufficiency, or unplanned blood transfusion, etc. So then they further analyzed and they found that which are the patients who are more prone. Is every patient to these complications, or can they be categorized into certain subcategories? And a focus work can be done in those patients to identify which amongst these patients with obesity were more prone. So they found that to top the chart was the dependent physical status. So when a patient has a dependent physical status or is suffering from cardiorespiratory compromise, is having, uncontrolled hypertension or extreme BMI, now these form some large group of patients who were more prone to adverse events. So many guidelines have then defined the goal of pre-op assessment. So the goal of pre-op assessment is to definitely, first of all, red flag these patients who might be suffering from these conditions or having a dependent. So appropriate selection, identifying associated medical conditions to risk stratify them, to optimize all medical conditions that are associated in the patient and to enhance the functional capacity of the patient should remain the major goal of preoperative assessment. So what do our guidelines say? So, for example, the recent guidelines of enhanced recovery after surgery program in bariatric patients that were published in 2022 and how they were different from the previous guidelines that were published in 2016. Now, the guidelines that were published in 2016 focused on the rehabilitation and enhanced recovery after surgery. Whereas if we see these guidelines, we see that what they said was that the previous guidelines were more on rehabilitation, and the current guidelines are more, they act before the process of the surgery starts. So they are more on rehabilitation. So they say that interventions to address complications are much before the process of surgery. So the focus should happen before even the patient is getting admitted for an elective surgery. So the gist of that guideline is that to move enhanced recovery forward, we have to start before surgery. So there is the concept of rehabilitation that takes a major place in managing these patients. And if we look into other studies as well that have been published, they say that most successful intervention is exercise. And why do we need exercise? Because we want to increase the functional capacity of the patient. The same basis can be seen in the guidelines by the American Society of Metabolic and Bariatric Surgeons and the Multi-Society Clinical Practice Guidelines, which are summation of American Gastroenterology and ASA and ASMBS guidelines. So the gist of all of them is that we have to find out the patients, which amongst our patients is more prone to adverse events and which of these patients should definitely be subjected to rehabilitation. Because, for example, if a patient is coming to us for with a certain BMI, let's say for gallbladder surgery, not like 100% of the patients have to be subjected to rehabilitation. So we should be able to identify those patients who are coming for elective surgery, which of these patients need a focus attention, and those areas need to be red flagged. So dependent physical status. If a patient is walking into our pre-op clinic on a wheelchair, a patient is sitting with hardly any energy and maybe even falling asleep while talking to the anesthesiologist, or the attendants of the patient will have to give history. Now, these patients should be looked at with a lot of suspicion because patients hardly any energy. So why is that happening? That is a clear signal of oxygen reserves of the patient, and we must investigate whether the patient is suffering from a condition, maybe obesity, hypoventilation syndrome. So these patients definitely should catch our attention. Now, what exactly is rehabilitation? So rehabilitation involves preparing the patient for the stress of surgery by initiating the recovery process before the surgery and hence enhancing the pre-op functional capacity. Now, these conditions should be definitely red flags. So enhancing of functional capacity, assessing the oxygen reserves and optimizing and building the oxygen reserves, assessing the associated medical conditions and optimizing them wherever possible, assessing even the nutrition. Then cessation of smoking and alcohol remain an essential component of pre-op instructions, I think, across all specialties. And then identify those patients which would be needing periodic assessment. For example, if a patient has come with very severe sleep apnea and is planned for an elective surgery, fine, we subject them to rehabilitation, we subject them to, a pre-op exercises or an IV support, but then we have to define when that patient becomes eligible for the surgery. So we have to call the patient for reassessment. So that is what is meant by identifying patients for periodic assessment. So how do we assess the oxygen reserves and how do we build up the reserves? Oxygen reserves, we need some very basic sciences that we have learned right through our undergrad to the training years of our anesthesia training periods. We know that simple thing like breath holding test. So if we are able to do some breath holding time for the patient, if the patient is unable to complete a sentence while talking, if the patient is sitting and unable to converse or is falling asleep, we have to red flag these patients. Then, moving to a little more intense investigation could be a 6-minute walk test. We should be able to rely on more clinical tests rather than depending more and more on imaging or other interventional investigations. So that is something that we all need to understand. So why do we need to understand the basic reserve of the patient? Because hypoxemia forms the basis of anesthetic management at every step, right from the pre-op assessment to induction, the process of airway management being maintenance, emergence, post-operative period, and even after the patient is discharged. So the hypoxemia is a fundamental suffering of an obese patient that the anesthesiologist should be able to pick up right in the pre-op assessment and should remain at the front of our assessment throughout the course of the patient. And at every step, we should familiarize the patient and sometimes the patient's attendants who are going to manage the patient. Now, for example, if a patient is sleep apneic and the patient has been put on NIV support, and while the patient is in hospital, is in a monitored environment, everything is fine. But when the patient goes back, when the NIV machine is off, if we do not have a responsible attendant, then before we will realize, patient may slip into an apneic phase without, the patient or the family realizing. So one important part of our pre-op assessment should also be educating the attendant. So we have discussed the assessment of oxygen reserves. Coming back to the previous slide, the simple X-ray chest. X-ray chest itself can give us a good idea of restrictive lung disease. So we do not always depend upon a pulmonary function test. If the patient is carrying an X-ray chest, we can just have a look and get an idea of how much are the lung reserves of the patient. So we have to optimize and assess the airway and optimize the simple things like educating the patient and the family that patient should be maintained in head-up position whenever possible. While the patient is sleeping, indulging them in some deep exercises and picking up the patients who need NIV. So all these measures will help in recruiting more and more alveoli and opening up the airway. And if we educate the patient, that patient will have to follow these same principles throughout the hospital stay and even after the discharge. And for those subgroup of the patients are probably undergoing bariatric surgery till on such time that they start losing weight, they have to, wherever possible, maintain a head-up position or a lateral position and know the importance of airway collapse that can happen just by not practicing a good position. So when we look at the associated medical conditions, which medical condition forms the basis of or which forms the most important comorbid condition in these patients is obstructive sleep apnea. Now, if we look at the statistics, we will see that most of the adverse events that happen in the perioperative period is in the patients who are having some sort of a sleep disordered breathing. So in the pre-op period, we should be able to triage which of the patients need more serious care on the part of the peri-op team. So screening the OSA and OHS patients, identifying the patients who might be having reflux or are prone for reflux, in the peri-op period, and pre-declare to the patient whether the patient will be shifted to the ward or to the HDU. Then we have a subgroup of patients. I'm not sure if Nagin is covering this in his lecture or not. Some of the patients would be on GLP-1 receptor agonists. Now, these are the patients who might be still continuing these medications. So we have seen the recent guidelines which highlight that these patients are in a full stomach state. So we should be able to identify which of these patients are having medications and whether they are in a full stomach state or not. So if they are having weekly medication, the patient should be told to, stop the medication at least a week prior. If they are on daily medication, then it should be stopped at least a day prior. And despite that, on admission, we should be able to reassess whether the patient is in a full stomach state. And wherever possible, if we have ultrasound available, then we should be able to assess the gastric content so that we can plan the airway better and we can prevent any airway catastrophe happening. So as we just discussed, that patients with sleep disordered breathing would be having maximum adverse events and in the post-operative period. And amongst the obstructive sleep apnea patients, those patients who have a more than 6 or who have a large neck or who have a very high BMI are more and more prone for having obstructive events in the post-operative period. And stop bank score has become so handy. It is so widely known. It is so widely used. And we all are aware that it has been shown to have very close correlation with the sleep, the conventional sleep study like the polysomnography. Whichever centers we do not have, facilities for a sleep study, stop bank is very, very handy and very, very informative. So we have chalked out the perioperative concerns. So amongst these, the most important would be the regurgitation and pulmonary aspiration, airway obstruction, cardiovascular complications, and wherever possible, renal dysfunction, rhabdomyolysis, and venous thromboembolism should be predicted and preempted wherever possible. So maintaining the patient in a propped up position throughout the peri-op period, starting from the time the patient first meets the anesthesiologist, even if it is a couple of weeks, for which we have to wait for some patients, is extremely beneficial. So this very vulnerable patient would be having a high stop bank score and might even be having risk for venous thromboembolism. So risk assessment is, a summation of procedure-related risk, physiology-related risk, and the risks associated with the medical conditions that patient is suffering from. So we should be able to chart out our planning based on all the 3 conditions and have targeted, approach to optimize each segment of the risk factors that we may be encountering. And wherever possible, patients should be informed about what conditions, what can prolong the stay of the patient. And this is not just dependent on the BMI. Even if the BMI is not very high, but the neck circumference, for example, is high. So that patient would be at a higher risk than a patient who has a high BMI but a normal neck. So, we have to unlearn what we have learned that, just a high BMI does not mean a very high risk. So we have to look at other things also. So there is this very handy Edmonton obesity staging system for functional risk and not BMI alone that we can share the PDF of this with all of you. So it is very similar to the ASA. So here, we have to focus on the end organ function. So more and more organs that are involved and more derangements, for example, renal dysfunction or a cardiorespiratory event that might have happened, or if patient is having severe osteoarthritis. So these patients are definitely at a higher risk, and we should be able to document all of this in our informed consent, and patient must be made aware of all the comorbid conditions and all the associated risk factors. Then other thing that we have to make note of is the airway difficult. Now, if the airway is difficult, then we have to plan the airway accordingly. So we have to have, if we have a airway which might be appearing to be very, very challenging, like a very large neck or a very large tongue with limited mouth opening, and many more features, then we should be able to plan, we should be able to keep a video laryngoscope ready. We should have a helping hand available inside the OT. We should have rescue devices like supraglottic devices. And so these things should, put us in a frame of alert. So we should all the time be alert about, these things from happening. And we should take all measures to prevent any catastrophe from happening. So we all have learned about ramp position. We all have learned about using an IV in the immediate pre-op period, end-tidal CO2 monitoring, importance of maintaining head-up position, and keeping high-flow nasal oxygenation wherever indicated ready. So, not much time I will spend on the exact anesthesia strategy that we can discuss in some other webinar. I want to focus more on the post and the emergence periods. The drug dosing has to be very finely curated, the ventilatory strategy, the choice of anesthetics, what anesthetic technique, are we using multimodal analgesia? So what anesthetic agents are we using, total intravenous or inhalational? Are we monitoring the bispectral index? So all these features, all these parameters have to be looked into, and it should be a teamwork. We should collaborate. We should, delegate responsibilities to different team members to take care of different things. So coming to the extubation, so extubation has to be very carefully done. We should be able to reverse the neuromuscular blocking agents, and wherever we do not have rocuronium or sugammadex, we should be even more careful about neuromuscular blockade. We should maintain a certain FiO2, and make sure that the patient maintains an SpO2, let's say more than 95%, or at least at the baseline, with minimum possible oxygen requirement in the post-operative period. So the performing recruitment maneuver, keeping nasal airway ready are extremely crucial. Now, in the post-operative period, for the patients who were already on a non-invasive support, non-invasive ventilatory support, then in those patients, we can start them on an NIV machine already. But if a patient was not previously on an NIV support, we should monitor the oxygen and the end-tidal CO2 wherever possible. And if the end-tidal CO2 is high, and if the SpO2 is not, let us say 100%, but is definitely above more than the baseline, then we should not hyperoxygenate the patient. We should try to give minimum possible oxygen, and wherever possible, we should try to give NIV support to maintain the ventilation and the oxygenation of the patient. So high inspired oxygen concentration may further impair the opioid-induced respiratory depression in these patients. So pain management is another very, very crucial thing. So what strategy for pain management used intra-op has an implication in the post-op as well. Supposing we use an epidural catheter and the patient is still having pain, then probably the catheter might have slipped. So those factors we have to keep in mind. And once the patient is post-op with us, and we must be super cautious of what analgesic. So a multimodal analgesia with minimum, like either opioid-free or opioid-sparing technique is what we have to start learning and practicing, because majority of the adverse events in the postoperative period are related to pain management, are related to airway obstruction in sleep apneic patients. And this close claim analysis that I was focusing here, they found that patients have a high risk of OSA who have a stop band score of more than 3, who have a large neck or are ASA grade 3 and more, and are obese, are more prone to the adverse events due to opioid administration. So be very, very cautious when the stop bank score is 6 or more, or when the neck is very large. So these patients definitely qualify for opioid sparing or opioid free technique. So we should be able to identify the analgesia failure. So if a patient looks, non-responsive or fully responsive, has shallow respiration, or has pinpoint pupil, this patient definitely is probably, having opioid-induced respiratory depression, and we should be able to identify them in the post-operative period. And so presence of naloxone in the post-op is extremely vital So other important adverse event that we have to be careful about is the venous thromboembolism. So early ambulation is extremely important. Patients have to be familiarized about the importance of early ambulation right at the time of our first visit to them. The post-operative staff and trainees who are taking care of the patients have to be familiarized with the importance of early ambulation and less sedation. And so this is what will qualify the patient for an earlier discharge, give the feeling of satisfaction, and expedite the patient's recovery. So patients who are on walkers or are using stick can be encouraged to bring the walkers to the hospital so that they can be made to ambulate with a walker as early as possible. So towards coming towards the conclusion of my presentation, we have to be very familiar with the screening tools. Like for obstructive sleep apnea, for risk assessment, we have to ensure availability of a non-invasive ventilation device in the post-operative period. And because not always it is possible to go opioid free. So if we are using a small amount of opioid, even that can be very detrimental in patients, especially those group of sleep apneics who have frequent hypoxemic episodes. In the pre-op, we should be able to identify. They are very prone to even the smallest dose of. So we should have naloxone ready. And we have to train the post-op care providers. And most importantly, we should document whatever we have informed the patient. Sometimes patients have informed refusal. For example, patient refuses a blood thinner. For example, patient refuses to use a non-invasive ventilatory device. So we should be able to document an informed refusal and make the patient's attendants also aware of that. And whenever possible, if it is not an emergency surgery, we should we should have a clear plan of how this patient can be taken up. So building functional capacity, risk stratification, building oxygen reserves, multimodal analgesia, practicing safe emergence and extubation, and thromboprophylaxis and early ambulation form the pillar of good perioperative care. So wherever possible, we have to involve the patient. So even the concept of enhanced recovery has evolved from what it was a decade back to what it is now. Now, the role of what we are doing with the patient right on the first visit, we are encouraging, how we are familiarizing them with their in the hospital has a major bearing on their outcome. So with that, I will conclude my presentation. And so whatever questions, whenever
Yes, thank you so much, Aparna.
Thank
I think
you.
that was quite an detailed overview. I think all of us will definitely benefit from all irrespective of our experience. It's been dealing with this subset of patients who are quite challenging in our day-to-day practice. I have a few points which
Yeah,
I
sure.
think probably if you had noticed or noted, if I missed it out. With respect to the preoperative preparation in these patients and with specifically concerning the investigations, would you subject all of these patients to echocardiogram, or is there any criteria for doing an echocardiogram in this subset of patients?
Echocardiogram, see, if I think most patients will be subjected to echocardiogram in our setup. And if a patient, as I said, has limited functional reserve, or is, wheelchair bound, or is having nephropathy, or is having some ECG changes and small breath holding time, if we are unable to assess the cardiorespiratory reserve of the patient, for example, definitely we will like to have, if a patient is severely sleep apneic, for example, is having high, then we will definitely like to know the right ventricular pressures. A lot of them do have high right ventricular pressure. So even a plain 2D echo is very, very informative. So that RVSP gives us a good idea of how much pulmonary hypoxemia is there. So it is not just about the cardiac functions, it also tells us about how much is the pulmonary reserve and how much is the back pressure because of high RVSP. So these patients, sometimes we like to subject them to pre-op diuretics, and then we like to reassess them. And these are the patients who we like to even do an arterial blood gas analysis to see how much pulmonary uh, component, is contributing towards low PO2. So yes, in a good number of patients, we will like to do today. I
I've
can't
just
hear
got
you.
one comment to make here. Is that
Yeah.
okay?
Yeah, sure.
No, one of the common things that we use is NT-proBNP blood
Yes,
test.
anti-proBNP is also definitely. Yeah.
Yeah, so
If I'm doubting heart failure, if I'm doubting, yeah, definitely
no,
anti-proBNP is
most of these patients, look, they have physical challenges to assess,
100%.
and it's already very difficult to assess their cardiopulmonary reserve because of their
Exactly.
joint issues,
Yeah.
their
Yeah.
immobility already existing. So for me, I use surrogative markers because
Yes.
uh,
Yes.
from our perspective, cardiopulmonary reserve is one criteria of
Yes.
perioperative outcomes. So for me, of course, CPET is gold standard, but it's not done everywhere. It's only in some very big gold standard institutes. But in day-to-day practice, um, one of the common predictors for us is the use of NT-proBNP in these
I
patients.
agree.
And then we just do that quite regularly.
Yes.
And
Yeah. Yeah.
also
So
what
whenever there
we've
is
got is,
yes, please. So
yeah,
whenever there's doubt, to differentiate the cardiac from the pulmonary component, anti-BNP definitely, gives us a very clear direction is how much is the cardiac component in the failure. Yes, absolutely.
yeah, that's right.
Yeah.
The pulmonary component is often the prediction is much better with CPET, but the cardiac component is much, you get a much better prediction from the NT-proBNP.
Anti-BNP.
So
Exactly.
that's what we use most often. Also, another thing I want to make comment is from prehabilitation. I was telling in the chat group that next month my talk in Mumbai is on prehabilitation in obese, in fact. So
Very nice.
like
Please share the link
watching.
with me. Yeah, I will love to join.
Yeah, it is such a coincidence, but it's
Yeah.
also the topic which is close to my heart, because I work with three bariatric surgeons, and then we got a whole team, and now we have developed a digital pathway where
Very nice.
it's all app based, and also most patients have got are provided with a like a iWatch like a thing. So, and then also in the app, they enter the weight on everyday basis. When they go on the VLCD or the LCD diet, whatever the dietitian has prescribed for them, they go on to the exercise program, which is all with the videos in the app itself. And then they record their exercises, they record their weight on an everyday basis. So our kind of assessment prior to surgery, almost all the stakeholders involved in surgery, from anesthetists to the surgeons to dietitians to physiotherapists, everybody knows the patient status prior to surgery. So that
Yes.
is one thing I think probably is a good tool to use in the near future, that patients can provide you with feedback about. So we don't operate on patients who have not lost at least 10% of their weight.
Yes. Yes.
No,
Same here.
that's
Yes.
our
I
kind
agree.
of cutoff where we found the post-operative mm, morbidity is significantly reduced
Yes.
at around
I agree.
10% of weight loss, whether use of GLP or not, and
Yes. Yes.
in conjunction with GLP plus VLCD plus exercise. Um, and so we kind of use that digital tool. to help with kind of monitoring. When you mentioned monitoring and
Sure.
progress,
Yeah.
that's what we do. That's all I've got to say. Thank you.
Yeah. Thank you so much.
Can I also make a quick point here?
Yes, please.
Yeah, I mean, everything has been covered very nicely between you and Guru. Thank you so much. At our center, we also send our patients to the psychological assessment as well. See
Right.
that sometimes these young patients, especially young girls in their 30s and 40s, they all have some kind of anxiety, depression issue. They're on all kind of those medications. So we also send them to psychological assessment to see how
Yes.
motivated they are, and they will be able to follow and be compliant in the post-operative period and try to change their lifestyle habits and choices. Just one
But
small
they
bit.
don't come
Thanks.
to, without psychologists, they are not in the program at all. That's true, Dr. Rachel. So psychologists are the most important part, because I think one of the greatest problems is binge eating, So if they don't achieve, I mean, this is all multidisciplinary, as we all know, right? So dietitian, psychologist, exercise physiotherapist, anesthesiologist, surgeon, all are involved, and even nobody misses each of these stakeholders.
Yeah, and so actually, so I think what I was also trying to present was, not just the patients who are for bariatric surgery, but obese patients even for non-bariatric surgery. So, I mean, there will be some group of patients who have to be just taken up maybe within a few days. Or, I mean, the patients who are coming for bariatric surgery, definitely we try to defer it by ensuring a certain amount of pre-op weight loss. But it is not always sort of feasible. But yes, patients who are coming for bariatric surgery, then 100% of them will meet the psychologist and the nutritionist. But those obese, not for bariatric surgery, not all of them will meet a nutritionist or a, a psychotherapist. Yeah. That's what I was also wondering. Yes, Nagendra wanted to say something. Nagendra, you're on mute, I think.
Sorry, yeah. In the
Yeah.
UK, we also do, for especially for me, irrespective of they come for bariatric or non-bariatric surgery, we also do like venous blood gas to see what their bicarbonate levels is, to see their
Yes,
susceptibility to
yes,
opioid
yes. Yeah,
dose. What's your view?
we
Do
do
you
it.
think that all
We do it.
is there a BMI cutoff, or do you all patients who are a certain BMI should have it?
So I think whenever clinically we feel that, patient, let us say patient is a diagnosed case of sleep apnea and has been advised NIV support, but patient is
Yes.
non-compliant and we have to take up the patient. So
Yeah.
good way to find out whether patient is compliant or not is to do a bicarb also. So that
Yeah.
counts one group of patients, right?
Perfect.
And if we don't have like too much time for the surgery, then also
Yeah.
it becomes a very handy tool to discuss with the surgeon that, look, this patient can be put on support for maybe another week and we reassess.
Perfect. Right.
Yeah.
Another
Yeah.
question is, do you have sort of a cutoff time or a minimum period of time for patients who go, or for say patients who have got obstructive sleep apnea and they are subjected to or prescribed CPAP mask therapy? Do you have any specific period of time before
No,
you
not
take up for
really.
surgery?
No, not really. So, most of the time, patient who has been subjected to an NIV support would also have been advised a low-calorie diet and sometimes a diuretic as well. We definitely want to call them after a week to reassess.
When would that
So
period be? Is there a period you would say for 2 weeks, 4 weeks, 6 weeks?
no, I think after a week we definitely call so that we find out whether the patient is able to understand also the how the mask has to be applied, because
Yeah.
otherwise we lose out on those 2 weeks. So
Right.
after
Because
1 week
here,
we want
In the SOBA website and also in the UK, it's a standard practice that the CPAP mask should be established for a minimum of 6 weeks before they are subjected to surgery. That's when the advantages of having the patient being on CPAP mask therapy is actually found out. So hence my question: is there anything you practice
Think
in
to
your
have any rigid 6 weeks. If we see that the patient is improving, we take up the patient. No, not
Okay.
necessarily 6 weeks. There will be
Okay.
very few patients who, yes.
I mean, I
Okay,
think
fine.
you're right. The real world is different from ideal world. What
True.
the SOBA or
We,
all the guidelines say. From real world perspective in the private practice,
Yeah,
most of the patients want to get on with surgery within a specified period of time and
true.
things like that. There are a lot
yeah,
of other restraints.
Nagin, I would tell you that a lot of patients we get even from UK who don't want
Yeah,
to wait for that period and they say
correct.
that,
I understand. Yes.
we
Yes,
want
yes.
to
I
come
know. I know.
and
By the
I know.
time
That's
they
what I'm
wait, they will
asking.
come here. They would have lost the weight and they don't need CPAP
yeah,
anymore.
but that does not mean that we compromise on the safety. But yeah,
No, no.
6 week period maybe can be bypassed.
Right.
Yeah,
I mean,
And
most of
is
them.
MI in your practice to say as day case? Say, would you do a patient with a BMI of 52 as a day case procedure, or would you say
I
no?
think it will depend on the surgery, but I would prefer that patient is admitted. I mean, if the surgery is under
Right.
general anesthesia, admitted for a day.
Right.
So most
Okay.
of our
Perfect.
Yeah,
patients who are under insurance cover are any which ways admitted for one day. So, but we don't have any criteria that above this BMI patient,
that's true. It
has
depends
Right.
to
on the
be.
type of surgery, isn't it? For
Yes.
Right.
simple hysteroscopy and DNC, which is a common occurrence in obese women, I have no cutoff because the surgical time is 15 minutes with minimal residual pain or
Right.
minimal post-op opioid
Yes.
requirements. They go home within 2, 3 hours, in fact. So, but if they are coming for, say, for example, a non-bariatric surgery for like a laparoscopy or for orthopedic
Cholecystectomy.
surgery or something like that, then definitely look, most people would play on the safer side to admit them, and admission also wouldn't be into the ward, so in a monitored care situation. So most of our patients, we play on the safe side to be in HDU like setup, or at least have a OSA monitored bed, where
Okay.
there is at least 1 to 2 or 1 to 3 monitoring with SATS monitoring kind of thing.
Oh, perfect. Okay. Thank you, Dr. So much, Dr. Aparna.
Thank you
Shall
so
we
much.
move on to the next
Yes,
presentations and
please.
then we
Yes,
can
yes,
go for
yes,
questions? Thank you so
yes.
much, Dr. Aparna. Very useful. Thank you. Okay,
Thank you.
so the next turn is I will share my screen. Okay. Can you see my screen now? Excuse
No,
me.
no.
We can see there are multiple things. So yeah, this one, and you want to start from the first slide?
Yeah.
Yeah, that's right. Okay. Yeah,
Is that clear now?
it is pretty good. Let me just check on YouTube. Does everyone see that? I think it's pretty good.
Okay. Let me go to my, yeah, okay. Can everybody see? Hear me, please?
Yes, yes.
Okay. Right. Okay. Right. Okay. I'm Nagendra. The other two topics for presentation for today would be the perioperative steroid cover and the management of fluorescence in the perioperative period. As we all are aware, the perioperative steroid management is quite an essential practice in our day-to-day anesthesia practice, and I'm sure we come across patients almost every single day. So I thought this would be quite a practical topic to have for us, and have some sort of discussion and see where we stand in the present day's practice. Okay, so we all know that the corticosteroids are widely used for all chronic conditions, specifically chronic conditions, and because they're used for such a long time, it can cause a suppression of the hypothalamo pituitary adrenal axis. And this suppression is not beneficial, especially when patients are under stress, be it an infection or for us as dealing with anesthetists, especially during surgery. And for some of us who practice intensive care medicine and also who also manage the post anesthesia care units, if they have been admitted in, say, for example, medical conditions like biliary sepsis or pancreatitis, presence of this suppression of the HPA axis can be fraught with quite a lot of complications, mainly because these patients would be at risk of adrenal crisis because they are not able to mount a surgical or a stress response. Just a recap of the physiology with respect to this cortisol secretion. Normal cortisol is approximately around 15 to 20 milligrams per day. And during a stress, especially like a surgery or any severe infection, it can go up to 5 to 10 fold. So the demand would be almost 150 to 300 milligrams. Then if your patient is on exogenous steroids, then there will be a continuous long-term suppression of the ACTH, which can lead to adrenal atrophy, and this can in turn cause a significant challenge for these patients when they are subjected to physiological stress or surgical stress. So the risk of, again, adrenal suppression is classified into low, moderate, and high, and it's important to know that the risks, irrespective of whether it's high or low or moderate, it persists if the steroids have been taken or any if the suppression has been there within the last for almost 12 months. So if it's high, if it's classified as the risk of adrenal suppression is classified as high if it is more than 20 milligrams of prednisolone is taken daily for more than 3 weeks. Moderate, between 5 to 20 milligrams of prednisolone, because this is the commonest steroid which is taken orally, and that's why it's taken as a reference, and it's around 5 to 20 milligrams daily for more than 3 weeks. And low, it's less than 5 milligrams per day for less than 3 weeks use. It also depends on the type of surgery they are going to be subjected to, or the kind of physiological stress they are subjected to. Now, needless to say, I'm sure we are all aware of this. The consequences of adrenal insufficiency is mainly response from the inability of the body to respond to the inflammatory process, which mainly causes severe vasodilatation leading to hypertension, and is usually unresponsive, and hence I'm sure the intensivists among us would agree. And also because giving steroids is one of the important interventions they do when there is an unresponsive hypertension. It can also give rise to severe hypoglycemia, and if there's hyponatremia, then along with hypotension, there's a severe risk of central nervous system signs and symptoms. This can also give rise to hyperkalemia, and if all of these occur at a very fast pace, the patient can go to multi-organ failure and shock, and very quickly deteriorate and lead to death. So when do we give steroid cover? So as I said, if the risk can last for almost up to 12 months if they've taken steroids, and so if the patient has been on steroids, systemic steroids in the last 12 months, we have to consider to give a steroid cover. So if it's for a minor surgery, say for example surface surgeries like hernia, cataract, or even breast surgeries like lumpectomies or sentinel node biopsy, you can just they're considered for as minor surgery. For moderate surgery, for hysterectomies and cholecystectomies, and for major surgeries like cardiac and esophagectomies, where there is significant body fluid changes and also a body cavity surgery. Okay, so the recommended regimens, this is for all for adults, is that if it's a minor surgery, you continue the dose which the patient was taking and give 25 milligrams of IV hydrocortisone induction. And the reference is to use for hydrocortisone because that's the one with a very good mineralocorticoid and glucocorticoid ratio, and that's the one which can be used as for intravenous dosing. And in the next few slides, I do think would also be giving you the conversion between the steroid doses. So usually this conversion between hydrocortisone and prednisolone is around 1:4. So if it's 5 milligrams of if the patient is taking 5 milligrams of prednisolone, it's roughly around equivalent to 20 milligrams of hydrocortisone. So roughly, if it's minor, so you ask the patient to take the dose and give 25 milligrams of IV hydrocortisone at induction. If it's a moderate surgery, then the usual dose, but then give hydrocortisone 25 milligrams followed by 100 milligrams in divided doses for 24 hours. And if it's a major surgery, continue your usual steroid dose on the morning of surgery. You can give 25 milligrams at induction or even 50 milligrams induction depending on the severity of the surgery, and give 100 milligrams for 24 hours for at next 2 to 3 days. Now, there is some, I do acknowledge there is some changes in the way this steroid regimen is practiced, mainly with respect to the way the steroid tapering is done if the patient is not able to take orally immediately. So if the patient has had, for example, major colorectal surgeries, then you will have to it's the fact that the patient will not be able to take orally for the next 3 days or even 4 days is quite a possibility, and so you will have to institute hydrocortisone therapy in discussion with the endocrinologist, and usually it's tapering starts around 200 milligrams on the first day to 100 milligrams the second day, and then in divided doses, that is usually 6 hourly, and then by the third or fourth day you go back to your normal minimal dose, which is around 25 milligrams 2 or 3 times a day, and then go to prednisolone by day 4 or day 5 if the patient is able to take orally, or even by NNG tube in administration. The practical considerations are, as I said, the IV hydrocortisone is used mainly because it's got a very good glucocorticoid to mineralocorticoid ratio, and if the patient is taking orally, then obviously you are converting it to IV if there is patient is not able to take orally. You would usually taper back to maintenance as early as possible, and the important thing, because of the way the steroids work, is to make sure that there is no complications from the steroid regimen implementation itself, which is mainly delayed wound healing, risk of infection, and hyperglycemia. Right, so I've just taken one of these slides from the YouTube. I'm sure many of you would have come across this. It's quite a very useful slide and very practically. I think I use it quite often in my practice. This is equivalent dose of your mineralocorticoid and glucocorticoid dose with respect to prednisolone and hydrocortisone, which is commonly used. We also have dexamethasone. Mainly, the dexamethasone, because the duration of action is such a long one, along with your betamethasone, which is some used in your inhaled steroids. And the equivalent glucocorticoid dose is almost quite small. That's why you wouldn't sometimes, you not necessarily supplement if somebody is on betamethasone. But if the patient is on prednisolone, then you institute the equivalent glucocorticoid dose under the mineralocorticoid dose, which is almost, considering you normally use prednisolone and hydrocortisone. That's the one we need to be concentrating on. So special situations, as I said, inhaled and topical steroids usually don't have to be need no cover, mainly because of the glucocorticoid and the mineralocorticoid ratios. Children is again, it's weight-based dosing. I am not privy to the dosing in the kids, and anybody who practices pediatric anesthesia, I'm sure, will be able to help us here. And in critically ill and septic patients, I think again, if they are already on steroids and if they are unresponsive, then I think it's understanding the risk-benefit ratio and how much steroids should be given, or on what's the endpoint has to be discussed, taking into the situation of the risk-based risk versus benefit ratio. So the key take-home messages are assess the steroid history, the dose, the duration, and the last dose taken, and again, what type of steroids have been taken, and cover for risk of suppression and the surgical stress, mainly the type of surgery undergone and how long will be the nil by mouth situation, and how to cover those situations. Then again, the regimen should be guided by the surgical stress level and also the individual patient's physiological condition. And always we have to take the risks versus balance ratio and see whether we avoid the over supplementation, because this can severely impair your glucose homeostasis, your risk, and your risk of wound healing, because there's significant delay, and also there is risk of infection in these patients. Thank you. Can anybody hear me? Still hear me now? Hello?
Yes.
Okay. Sure. Any discussions now, or should I go to my next one and then presentation, and then should we discuss later?
Dr. Achal has raised his hand.
Oh, yes, please, Dr. Achal.
Yeah, I can learn it. I'm going to discuss afterward. Just a quick short pointer. Nowadays, I think everybody gives some dexamethasone as prevention of post-op nausea, vomiting, plus help with the pain. And if I give, say, 8 milligrams to an average adult, which comes to about 150 milligrams of hydrocortisone,
Correct.
do you think we should consider that into our calculations, or that is a separate thing? Or when we are giving hydrocortisone, we do not give dexamethasone?
I think if you are giving hydrocortisone, I think it's very important to note that we don't have to give any additional doses of dexamethasone. And if you're, because of the way the steroids work, because of their beneficial effects with post-operative nausea, vomiting, more importantly, I think the beneficial effects of steroids is in your anti-inflammatory and analgesia properties. And I think if you are able to give adjust for the risk versus benefit ratio, I think dexamethasone would still be a good dose to be given, say up to sometimes in, for example, in joint replacement surgeries, I think it's now common practice to give almost 12 milligrams to 16 milligrams of dexamethasone as a single dose. We think it's very good. And if their patient, say for example, if the patient is type 2 diabetic and if their HbA1c has been within acceptable limits or less than between 48 to 55 or even 60, you could go up to 9.9 or 12 milligrams of dexamethasone with a monitoring of glucose in the post-operative period. Does that answer your question, Dr. Achal?
Yes, absolutely. Thank you so much.
Thank you. Any more clarifications? Can I go for the next one?
Yeah, please.
Okay, good. All right. All right. Can you see my slide, please? Here.
Yes,
Hello.
we do.
Yes,
Okay.
it is
Right.
visible.
Okay.
It is visible.
Okay, good. Right. The other topic I was going to discuss, I think it's quite topical these days and quite of in the current trend, is the introduction of this group of drugs called flozins. I'm sure everybody is been exposed to this group of drugs, and which has caused quite a bit of a consternation and a bit of confusion, at least in the last 6 to 12 months. Certainly, I was a bit. In the sense taken back when these drugs were introduced, and then when some of our patients started having the complication of euglycemic ketosis. And now I think most of the hospitals around the world and most of the trusts around here have come up with guidelines, and I thought it would be a good topic to discuss. So the four flozins which are quite commonly used, and they are the empagliflozin, dapagliflozin, canagliflozin, and eritagliflozin. Usually the doses are next to them. The empagliflozin and dapagliflozin is around 10 milligrams. Dapagliflozin sometimes is used in 5 to 10 milligrams. Canagliflozin is quite a high dose. It's around 100 milligrams because that much less potent. And the ertigliflozin is on 5 milligrams, but then it's very potent, and sometimes, and also also the duration of action is quite different from the others three, wherein it almost act for around 4 to 5 days, almost 96 hours to 100 to 120 hours. Uh, so how do this group of drugs act? This is called the SGLT2 inhibitors, the sodium glucose co-transporter receptor. This receptor mainly is in the S1 segment of the proximal tubule, immediately after the your glomerulus. That is where majority of your renal absorption of the glucose takes place, and this particular group of drug acts on this SGLT2 receptor. So what does it do when that SGLT2 receptors are inhibited? Almost 90% of the glucose which is filtered through the glomerulus is not reabsorbed back into the blood. It goes into the urine. And because we know that the glucose almost always is transported along with the sodium, there is an increased excretion of sodium as well, and so you have the added advantage of both the glucose and the sodium being excreted in increased quantities. This is the basic mechanism by which these SGLT2 inhibitors act. And so main effect of this SGLT2 inhibition is the prevention of the reabsorption of the glucose back into the bloodstream, causing more glucose and sodium to be excreted. Now, I'm sure most of us immediately would recognize the beneficial effects of this would be obviously decreased blood glucose levels, but because it acts on the sodium channels as well, and the sodium is excreted, the action on the blood pressure is quite significant and reduces the blood pressure on these significantly. And also because of these twin effects, the reduction of the blood pressure and the blood glucose levels, and also because of there is increased uresis, there is also a significant cardiovascular and renal protection. And combined with all these effects will also be the beneficial added feature of the weight loss. And so the indications, which initially started for type 2 diabetes mellitus, and because it acted in increasing the urine output along with increased sodium loss, it was also they started using in heart failure. And because it acted on the, it was used to decrease, they noticed that the progression of the patients with chronic kidney disease was also favorably impaired. That is the progression of the disease. And so these patients with chronic kidney disease with or without diabetes mellitus type 2 were also started having be treated with these drugs. And so the indications for these group of drugs are these three main indications, which is the type 2 diabetes mellitus, heart failure, and CKD without the diabetes. Why is this risk of the euglycemic diabetic ketoacidosis particularly seen with this group of patients so much important? Just to recap, the euglycemic diabetic ketoacidosis is defined as a diabetic ketoacidosis in the setting of a serum glucose level of less than 14 millimoles per liter. So usually in this group of patients, you would see glucose be around 10 and 11, but when you do the ketones, it could be raised. We'll come to that as to what the different levels of ketones are. But we all know that the ketosis is triggered by fasting, surgical stress, dehydration, and reduced insulin, which are all seen in a patient in the perioperative period. And so these patients who are on these drugs are very much vulnerable to developing euglycemic diabetic ketoacidosis. So this is one of the pathways which we had developed in our hospital for a perioperative management of SGLT2 inhibitors. So if you could classify them, patients having as emergency and elective procedures. Now, we recommended that they to stop these inhibitor drugs for at least 2 days prior to surgery. Now there's an asterisk mark, and the reason there is an asterisk mark is that when these drugs were initially noted to have this complication of euglycemic ketoacidosis, the associations of anesthetists in America, in Canada, and in the European countries, they were all quite unanimous in saying that it should be omitted for 3 days. But then when and we have to remember this guideline was for when these drugs were used primarily for diabetes, management of diabetes. But when the indications expanded to the management of heart failure and the management of chronic kidney disease, patients being omitted for almost for 3 days in these kind of patients had a negative effect. And so there was a discussion whether all these patients should be omitted for 2 days or 3 days, or can be continued till the day of surgery and monitor their ketones. And so what we decided in our hospital was to just make a standard guideline for all the types of surgeries, irrespective of orthopedic, non-orthopedic, gynecology or general surgery, as standard 2 days prior to surgery, so that there is no confusion. So if as the flow chart says, if on combination therapy, just consider switching it to a monotherapy for the cessation period. And if the patients have a reduced calorie intake pre-procedure, then that should also coincide with the reduced intake. But for if there is a minor surgical procedure, which we discussed in the discussion on the steroids, you need not stop the SGLT2 inhibitors, considering the benefits these patients have. But important to note that the monitoring of the blood glucose and ketones should be done most preoperatively and postoperatively, and make sure that there is no hypoglycemia, and if there is always access to rapid acting insulin is present, should be noted. And the resumption of these SGLT2 inhibitors should be as soon as possible, and especially when the patients start eating and drinking, and when they're euvolemic and medically stable. So you would meet all these conditions probably in patients who are undergoing some certain day-case procedures, and mainly in patients with orthopedic procedures, because most of them would have regional procedures, and they would be able to eat and drink probably in the 3 to 4 hours after the procedure. But for patients who are undergoing colorectal surgeries or upper GI surgeries, where they will not be able to, these are the group of patients we need to be extremely watchful. Needless to say, if patients are undergoing emergency procedures, then even if they've taken on the day of surgery, there's nothing much we can do about it other than to monitor the glucose, do ketones levels, and then see what the best strategy to institute. We'll come to that in a minute. So for example, if in the situation where these drugs have been taken inadvertently prior to surgery, if there are check for the signs of symptoms of DKA, and if there are signs and symptoms of DKA, whereas high tachycardia, increased thirst, increased urination, increased levels of ketones and or sugars, or even with the presence of sugars of around 11 to 12 millimoles, then reschedule procedure depending on the this is considering for the elective procedures. And even if it's an emergency procedure, then you will have to institute therapy and then make the decision depending on the urgency of the surgery. If the symptoms of signs and symptoms of DK are not present, then you have to assess whether the patient would be nil by mouth postoperatively. If the patient is not going to be nil by mouth postoperatively, and that is the patient can have food in the next 2 to 3 hours after the surgery, then discuss the risks and benefits of continuing the procedure, and then check by constantly monitoring the ketones and the blood glucose. And again, we need to hear there is different levels of ketones to be aware of. So if it is between the cutoff level is 1.5. Please remember that. Now we'll come to the other levels in a minute. And if it is more than 1.5, check, do a blood gas, arterial blood gas, that is, check the pH, check the anion gap. If the ketones are more than 3 or more than 1.5, I'll come to that, and the patient is acidotic, reschedule the procedure. If the patient is not acidotic and if the anion gap is less than 14, the patient is quite hemodynamically stable, then you can proceed with the procedure. Now, how would you, if the patient has had a euglycemic DKA, and how would you treat it? Now, so if the patient is on an SGLT2 inhibitor, do not restart this drug unless you have discussed with the diabetes team. Involve the diabetes team because they're quite useful. Start fluids, start monitoring of electrolytes, and make sure that the ketones are less than 0.6 and the electrolytes are within normal limits. Now, if the patient needs insulin, make sure that the patient also has been prescribed potassium, and make sure that the patient is also has been administered 5% glucodextrose, as we would do with variable rate insulin therapy. The DKA protocol should be continued till the ketones are less than 0.6 for at least 6 hours. The glucose are less than 14, and if their acidosis has been resolved with monitoring of the blood gas. Once the DKA protocol has been stopped, again continue to check the ketones for at least 2 hours for the next 24 to 48 hours, depending on the severity of the surgery and the physiology of the patient. Once the DKA has been resolved, then the patient can go back to on its long-acting or the short-acting insulin to control the glucose. But most importantly, it is making sure that these patients are having a continuous monitoring of their sugars and their ketones. Now, how would you monitor this level of ketones in the post-operative period? So there are different levels of ketones. So if it is up to 0.6, 0.6 to 0.9, 1 to 1.4 or 1.5, and greater than 1.5. Now, if it is less than 0.6, you measure the ketones, and if it's less than 0.6, you observe, you hydrate the patient. If it is between 0.6 to 0.9, prescribe appropriate fluids with preferably Hartmann, because it contains your electrolytes as well, and measure your blood ketones and monitor it. No, therapy is not needed at this point in time. If it is between 1 to 1.4, then you have to have, in addition to ketone monitoring, you will have to start prescribing insulin with this variable rate, and to make sure that the ketone levels do not increase any further. If the levels of ketones is more than 1.5 or less equivalent to 1.5, then you will have to institute the arterial blood gas, then the management of the DKA protocol, and shifting the patient to probably an HTU. So when would you restart these drugs? You restart these drugs only when the patient is eating and drinking normally, and the acidosis and the ketosis is completely resolved. Obviously, the hemodynamically, if the patient is hemodynamically stable, and there is something known as sick day rules, wherein these patients can also cause significant predisposition to fungal infection and infection in the groin region, and especially the urinary tract infections. And so these patients, these drugs should be avoided in that particular situation. Red flags are, again, these are the signs that the patient becomes nausea, vomiting, with abdominal discomfort, abdominal pain, tachypnea, small breathing, which is the signs and symptoms of your DKA. Acidosis with normal sugars, and the blood ketones, it should have been more than 1.5. That's not 1 millimoles, but 1.5 millimoles. Key takeaways are, so stop flozins for 2 days pre-op. As I said, 4 days for atogliflozin, because it acts for a considerably longer time. Always have a high degree of suspicion for diagnosing euglycemic DKA in this patient if the patient becomes very unwell post-operatively. Restart only when it's safe, when the patients are eating stable and there is no ketosis, and educate the patients on sick day guidance. Thank you. Hello. Has anybody ever lulled everybody into sleep now? Or
No,
is anybody...
no, we have enjoyed your
Everyone is
lecture.
Very nice class, sir.
Yes, I think now we would be happy to take questions for all the 3 topics from all the esteemed people who have kindly joined us. Guru, do you have any questions from the
I've got one question for Dr. Aparda.
Yes, please.
One person has
Right.
asked is the dose of low molecular weight heparin in
Yeah. I have
pre-op and
actually
post-op.
written that answer.
Yeah.
So we do not monitor anti-10A activity. So we keep the dose most of the time as 40 milligram of Clexane, that is enoxaparin, in majority of the patients. I mean, we do not increase according to the total weight. So uh, matlab we stick to multi-pronged approach, like patient would have a sequential compression device, patient would be ambulating or having leg movements, and this dose. And so we rarely increase the dose proportionate to the increase in absolute body weight.
So you usually keep it at 40.
40, yes.
Yeah. Irrespective of their weight,
Yes, yes,
120,
yes.
180 kilos. Okay.
Yeah.
Okay.
And what
So
about your center? How do you manage?
no, look, I think it is dependent on the weight. Up to
Yes,
120 kilos, we keep it 40 milligram, and above
yeah,
120, we go up to 60 milligram.
yeah,
Usually, the first dose is given 6 to 8 hours post surgery, and
yes,
depending on the surgery, look, if it is bit woozy, the surgeon would say, "We'll give it
yes, yes,
next day morning
yeah,
rather than 6 to 8 hours." If everything goes well, the
uh,
first dose happens that night of surgery.
yeah, yeah,
With the
yeah,
antibiotics, like up to 120 kilos, it's 2 grams cefazolin that we use, and after 120 kilograms, it's 3 grams of cefazolin. Um, I was told of by the infectious diseases people saying that, you have to make sure you give a adequate dosing of prophylactic antibiotics. So we give 3 grams for anyone who is actual body weight is more than 120 kilos. We give 3 grams.
yes.
What would be your antibiotic prophylaxis of choice in the subcontinent in your practice?
Subcontinent, I will not be able to comment about what others are using. But
Mm-hmm.
yes, we do increase the dose of antibiotics proportionately. So usually a single loading dose is given. We
Mm-hmm.
don't sort of repeat the antibiotic later. So one
Okay.
single dose is given pre-operatively before the incision. So the
Yeah.
antibiotic of choice is cefuroxime
Okay.
in our center, yes.
Sure. Okay.
So I would
Uh,
not be able to sort of tell what other centers in India are using.
Mm-hmm.
Dr. Achal has a question. He has raised his hand. Dr. Achal.
Yes, thank you so much for an excellent symposium. So first, since Guru already asked that question about dose of antibiotics, so we also go by the body weight. So it is ideal body weight is more than 100. Then we give 3 grams of answer for cefazolin. And if it is a colorectal surgery, we redose every 4 hours. Especially we're talking about cervical or something, then definitely we redose every 4 hours. So that is related to the answer part. And now just comment about Dr. Nagendra's second talk. Uh,
Yes, sir.
yes, this group of drugs initially were for diabetes and add on to kidney failure, and definitely for heart failure. In the beginning, they were for low ejection fraction heart failure, but recently, I think for last 2 3 years, they also found that they are also good for patients with
So,
heart failure with preserved ejection fraction. So they're very good drugs. So my comment is that it is very difficult for these patients to understand what drugs to stop when. So what
Correct.
I do in my clinical practice is I say 1 week before, no vitamin supplements or herbal medications or a major anti-platelet agent like Plavix. 5 days before, no warfarin or aspirin. That is the standard guideline. Of course, this varies from patient to patient. And 3 days before, all these group of drugs which you just described, as well as any apixaban or rivaroxaban, if you're thinking of having some kind of neuroaxial block. So that patient understands 7 days, 5 days, 3 days, And one day before, again, if these patients are ACE inhibitors or ARBs, so if it is a significant long surgery, not a simple day surgery or so, then I
Yes.
ask them to stop a day before as well. And on the day of surgery, I specify that you please take your regular other cardiac medications and also take any proton pump inhibitor if they are on, and not insulin or metformin on the day of surgery. So this can be quite a challenging task for the patient to understand or their families. And these patients usually are on a whole lot of these different groups of drugs.
Correct.
So that is my just a comment. Thanks.
No,
Yeah.
very useful, very useful. Yes, because we also had this problem, and so there was different surgeons were prescribing different stop dates, and patients used to take these drugs. And when we used to check the ketones in the post-operative period, some had 3.5, some had to go to ITUs. We had a lot of problems, and then we also had the situations wherein that the patients were cancelled on the day of surgery because they had taken the day before. So it led to a lot of logistical issues, and so that's why we said as a blanket a guideline, 2 days, irrespective of the indications you're taking, so that everybody is on board. It seems to be working well so far. And I think I should have also added, there was one of the questions I had was asked when I presented here was that should you measure ketones before the surgery at all? I don't think it's necessary, because what would you do if you measure the ketones before the surgery? I think it's going to be unnecessarily a red herring. So I think we have stopped measuring ketones before surgery. Sorry, Guru, you wanted to say
No,
something?
no. Look, bedside ketones, like just like blood sugar with a finger prick.
Finger prick can be done.
I don't know about other places in India whether they have ketone as bedside. We do it, and I make sure it is done. And
Yeah.
if it is more than one, actually, I kind of proactively start that and also alert the ICU so that they go, it. I think whether it will improve clinical outcomes or not, I'm not sure. Yes, it does become a little bit of extra headache for us as anesthetists, that you're doing one extra effort of giving dextrose containing fluids plus insulin plus all those things. But I think trying to keep that around one is something I'm following. So if it is less than one, the ketones, I'm not first. We just do measure post-operatively, and
Yes.
so definitely all patients, even if they have stopped 3 days prior, I do measure ketones. But from my experience, 99.9% of them, or 99% of them, don't have any values more than one if they have stopped 3 days prior,
Yeah.
Uh, uh, and coincidentally, those who haven't stopped because of communication issues, or, as you know, they're on multiple medication, they're all confused, they just continue to take, or just lack of education, or blame it on whatever it is. We measured ketones, and it is rare to find very high ketones, even when they have taken
Yeah, man. Yeah,
posins.
most.
So to be
Yeah.
honest, in a way, it's coming around the circle, that saying that should we really measure, when actually even when they've taken, their ketones are not very high. Um, but then look, in this litigious world, I think it is better to be safe and do
Yeah.
some proactive measures, that you've done the right thing.
Thing.
It
Yes.
literally takes 30 seconds.
Yes. It's just a finger prick. So I think we should. I think, yeah.
Yeah,
If the
that's
patient.
my comment. Yeah.
Yeah. So sorry, my can I ask Dr. Minati a few clarifications, please, for the benefit of the group who joined us. Now, in managing, Dr. Minati, you're on mute.
Yeah.
Yeah. Is there any target heart rate you would have for these patients on atrial fibrillation before you say
Yes,
you can proceed with surgery?
yes, there is a target heart rate. Suppose the patient is not hemodynamic, does not have any hemodynamics instability, or does not have any cardiac failure or dilated cardiomyopathy like those who depend upon the heart rate, in that case you can keep 100 to 110. Otherwise 80 is the best one. At least you should come down to 80. Lesser than that is also good, but at least minimum heart rate target it should be 80 when you are going for the rate control.
Say, for example, if you have a patient whose heart atrial fibrillation rate is around, say, 120, on that,
Yeah.
when the patient comes to anesthetic room, what would you do? Would you postpone surgery, or would you go ahead with surgery after instituting control mechanisms, rate control
No,
mechanism?
we will not postpone the surgery. We'll go for the rate control mechanism and we'll go away with the surgery, because
Okay,
that 120 heart rate is not that uh, much also, which can reduce the diastolic feeling and give rise to problems. So I'll go with the surgery.
That's
you would
very
carry on with,
good point, actually.
yeah,
Had a few experiences with some anesthetists refusing, say there is paroxysmal AF, and but
yeah,
then jump in pre-op anxiety and other things.
yes,
Patient
yeah,
comes for surgery and at holding bay, heart rate is high,
yeah,
and then they instinctively
cancel,
cancel, and then to the upset of the patient, the
yeah,
surgeon, everybody, it is such a big mess. I think
yes,
it's important takeaway message. Look at up to 120-ish. The diastolic filling of what Dr. Minati said is not really compromised. And yes, bear in mind that you need to start to think about rate control, eliminating predisposing factors, and make sure, like somebody commented on the YouTube, that analgesia is very critical. You know, so this was a patient who was cancelled, was with fracture, bimalleolar ankle, who was in pain, and if you actually then do all those necessary measures and go ahead with surgery, actually the outcomes may be much better rather than just canceling and trying to
canceling procedure,
yeah.
yeah.
Yes.
Dr. Achal, you wanted to come in?
Yes. So I take it this way that I have canceled few patients, two surgeries. One I clearly remember is a liver transplant patient. And as soon as we put the ECG electrodes in the operating room, patient was in rapid AFib. I immediately see the preoperative ECG before that. And if it is a sinus rhythm, and this is the first time you see or diagnose that patient is in rapid AFib, previously sinus rhythm, definitely patient needs to be optimized and should not proceed with any surgery, elective or otherwise, unless
Right,
we do something. If a patient already is known case of atrial fibrillation, and now you see that it is a rapid rate, that is a different story. Totally, totally different. And then, of course, we try to give some IV drugs to decrease the rate, like starting with sedation, maybe calcium channel blocker or beta blocker, and make sure every electrolytes are fine, we carry on the surgery. But if it is a first-time diagnosis with previous no record of whether patient was in sinus or AFib, I would be very reluctant to carry on the elective surgery. That is
okay.
my 2 cents.
Thank you. Dr.
That's the
Minati, one
whole
more
idea of
final question.
paroxysmal, isn't it? Because the physician who was involved in this case, the anesthetic, look, patient was in sinus rhythm, now in AF. So the anesthetist said, look, patient was in sinus rhythm, now in AM, I'm going to cancel it. And the physician kept saying, look, it's paroxysmal AF. He would be in sinus every now and then, and most often in sinus than in AF. Uh,
Yes,
so just being in
Exactly.
sinus doesn't
yeah,
necessarily mean, so in the sense that the word paroxysmal is, I think, very important to notice that it does not necessarily manifest on a everyday basis, right?
And
Yes.
yeah,
that is
yeah,
the most difficult group of patients. So what I
correct.
meant to say was, if patient is not diagnosed with AFib, not
Right, then,
paroxysmal
yeah,
AFib is AFib. If previously sinus rhythm, no diagnosis of AFib of any sort,
And there is,
paroxysmal or Yeah, so
Yeah.
that is my
Very
point here.
Yeah.
Dr. Minati, one more thing. For final guys, with respect to investigations in patients with atrial fibrillation, what's your take on measuring BNP in this pro BNP in these patients? And
Uh,
another question is whether when would you subject all patients with atrial fibrillation for echocardiogram?
Not exactly, but yes, if the patient is having persistent arterial fibrillation or permanent arterial fibrillation, just to rule out a thrombus, yes, transthoracic echo we can go for. If the patient is supposed undergoing a major surgery or the thoracic surgery, when you are going to manipulate the things around, so there might be dislodgement of thrombus and all. But if it is
Right.
not, you're going for a minor surgery on the skin grafting and all, you not necessarily should go for it if there is proper rate and rhythm control.
Right. Okay. Good. What about BNP? Would you measure BNP in patients with atrial
That
fibrillation?
is again depending upon the patient. If the patient is having some form of the cardiac compromise and having other critical illness, yes, it's a better to go for a BNP.
BNP. Okay.
Yes.
But Dr. Achal, this is for everybody. Now, we have seen in patients who are in atrial fibrillation and in heart failure, even with preserved ejection fraction, the BNP is slightly raised in this group of patients. And the BNP will usually be raised in patients with chronic kidney disease as well. So, how would you then correlate this raised BNP, which might say that the patient is in failure, even though the patient might not be symptomatic?
Very simple answer. I will send the patient to internal medicine or cardiology for their expert opinion. See, we are perioperative physicians for sure. We can manage these patients, but for a proper diagnosis and proper thing, I think a specialist should look into that. You're
Right.
absolutely right. Little bit of renal dysfunction, little bit of cardiac issues, and with AFib, with slightly rise in pro anti-BNP, number one, what I will do is we protocol for MIMS to myocardial injury during non-cardiac surgery. So to the baseline troponin and anti-proBNP plus ECG, and 24 hours later, both troponin and ECGs if BNP was high. And all
Right.
we have those special group of patients who have high incidence of going into major adverse cardiac events. For that, we use this MINS protocol for such
Okay.
patients. And I
Okay.
would also, just for the benefit of the audience, I don't know what level they are. I still remember in my medicine in 1970s, when I read in the medicine book was, if atrial fibrillation is present in a child, always look for congenital heart disease. If atrial fibrillation happens in a young patient, always look for thyroid function. And if atrial fibrillation happens in a little bit elderly patient, always look for coronary artery disease. So to answer your first question to Dr. Menati first, that do we go for echo? If it is a first-time diagnosis of AFib, I think absolutely yes. But if the echo has already been done and they have already ruled out the structural heart disease, and this is just isolated AFib, and then there is, I don't think, no need to repeat the echo again. If they're already on blood thinners and already on the rate control therapy. And number two, if these patients are coming for ablation, which we do, these patients for ablation, and then we probably do not do any more investigation. And bottom line is, if their exercise tolerance is more than 4 max, 4 metabolic equivalent units, probably there is no need to measure this pro-BNP or any other stuff.
Right.
If they're
Okay.
physically okay and no symptoms, probably they're good to go.
Okay.
Yes.
Good. Thank
There
you so
is a
much.
question from
Ah,
one doctor online on YouTube. Please
yes, please.
explain VR2 in short if you can. I don't know what that stands for.
Uh,
VR2.
the
Mm.
variable rate insulin.
Ah,
Variable rate insulin institution. Sorry, I should have expanded. Variable rate insulin. Sorry.
Okay, so
Sorry, my mistake.
I will clarify that we are double, yeah, is variable
Rate insulin institution. That's it.
insulin institution. Okay.
Sorry.
Guru, I was thinking about ventricular rate response in AFib with rapid ventricular rate.
Okay, so there is another question.
Yeah.
Say how to attain glycemic control if
Yes.
SGLT2 are to be stopped 2 days prior if the patient is on this group only.
How
So
to achieve?
glycemic control. Say you stop SGLT2 inhibitors 2 days prior to surgery
Yes.
for a patient who is diabetic who is on this medication.
Yeah. Now, I think it's important to note that this group of drugs, one of the main treatment indications is that this should not be the sole group of drugs to be there. They should be on other drugs, and then
Mhm.
only these drugs should be started. So the chances of these drugs, patients being only on these drugs, is very, I think it's almost nil. But if the patients are only on these drugs, say for example, other than for diabetes and for any other conditions, they monitor blood glucose and institute insulin, variable rate insulin therapy. That's what we would do. But it's very, very unlikely that this will be the only group of drugs the patients would be on, because speaking to the endocrinologist, this group of drugs is quite, it's got quite a niche indication, and it can only be started when the patients are on other drugs.
That's right. Look, when I last spoke to, I have talked with an endocrinologist on the meduses on this particular topic. So the indication has been that once they are on like metformin plus other biguanides and other things, and
And
if
glycosides, yeah.
glycides and things like that. And if still their HbA1c is more than 7, it's the indication comes only then.
Yeah.
That's on what we call as the pharmaceutical benefit scheme in Australia. So you
Yes.
can't have it on a discounted rate, but again, patients can be prescribed. There is no rule that you can't prescribe them. So you
Yes.
can have a patient who is on just metformin and this medication.
Yeah.
Um, but generally speaking, in the stepwise, but honestly, considering those cardiovascular and renal benefits of SGLT2 inhibitors,
Yes.
nowadays, the biguanides and glycosides and all those things, people are jumping right from metformin plus straight away to SGLT2 inhibitor.
SGLT2, yeah.
But those are those patients whose glycemic control are not so much in trouble, to be honest.
Correct.
You know,
Correct. That's correct.
so as you said, you just get them admitted, do a blood sugar at bedside when they get admitted, and then take it from there.
Correct. Yeah. That's what the management guidelines here are as well. Yeah.
Yeah. Okay.
Good.
Any other questions?
I
No.
again have a
Yes. Sorry,
comment.
Achal. Yes. Please. Yes. Please go
Yeah.
ahead, Dr. Achal. Yes. Yes.
So I'll be happy to take another webinar on just on inotropes. So just to
Oh.
mention about these HELT2 inhibitors. So of
Yeah,
course
okay.
they started as anti-diabetic drugs, and then they found out there is some more than that effect
Yeah.
on renal as well as cardiac protection.
Correct.
So nowadays we classify these inotropes into three
Right.
categories. The commonest we use normally day to day, may it be dopamine, dopamine, epinephrine, or epinephrine, they all come with the category of calcitropes. They increase the
Correct.
calcium cycling in the myocardium. The second
Correct.
group of drugs is called myotropes, related to myosin. So either they increase the myosin bonding or they can decrease the myosin bonding. The myosin bonding positive drugs, they're a group of drugs to use for this dilated cardiomyopathy and other cardiomyopathies. They do not increase the oxygen consumption of the myocardium. So they're very, very exciting group of drugs called myotropes. On the negative side of myotropes is used in patients with hypertrophic cardiomyopathy. They decrease the myosin bonding and thereby patients' hypertrophy becomes less. The third group of drugs is known as mitotropes. They act through the mitochondrial level. And these SGLT2 drugs, after they found that they are helpful in heart failure, then they did further studies and found out that these group of drugs act through the mitochondria and not just taking the glucose out that is there, but they are also the mitotropes, thereby have multisystemic effect and which last longer than just stopping for 3 days or so. So in a nutshell, yes, their action is much beyond for diabetes.
That's
Thank
great.
you.
That
brilliant.
I think that forms our next webinar.
Yeah,
We're
yeah.
getting up for that. I think that will be very insightful. Thank you very much.
Thank you. I think Guru and Achal, should we call and Dr. Minute, should we call it time now? I think
Yeah,
it's
that's
been
right.
2 hours. Thank you so much for everybody for
Yeah.
contributing so enthusiastically. Guru, again, thank you so much for facilitating this. I think without you, we would not have
If
been
you
able to do
can
it.
just make me the host, I will end all the.
Yes, please.
things and everything.
Yeah, and Dr.
Make me
Minati,
the
thank you
host.
so much. Much appreciated. Thanks again, Dr. Achal. Thanks again, Dheeraj. Thank you, and thanks again for everybody who have attended this session. All right. Thanks, Guru.
Thank you all. Thank you all.
Yeah.
Thank
Make
you
me
so
host
much. It was
now.
very
Thank you, Dr.
informative.
Aparna.
Thanks.
Sorry,
Good
Dr.
night,
Aparna has
everyone.
left, I think.
Aparna's
But
left.
thank
Yeah.
you so much.
Yeah.
Yeah,
Yeah. Can you make me host now so that I
yeah,
can?
I will. Right.